Can I just invite the panel members to the stage, please? Professor AlHazzaa, Professor Hassan Elsolh, Professor Moeen Al-Sayed, and Dr. Wonnacott, please. Thank you all. It's been a long but exciting day. My name is Meyer. I am the chairman of the Research Center Department of Genetics at King Faisal Specialist Hospital and Research Center in Riyadh. It gives me great pleasure to moderate this wonderful panel. May I start by introducing Dr. Wonnacott, who from this morning we know has spent 13 years with the FDA and now is a consultant in regulatory matters with Pfizer. Professor AlHazzaa, a consultant ophthalmologist, a retinologist with a specific interest in inherited diseases of the retina. I could go on for longer, but time does not permit. Professor Moeen Al-Sayed, who chairs the Department of Medical Genetics at King Faisal Specialist Hospital, and probably arguably runs the department with the widest experience in the world with respect to rare inherited diseases, and Professor Hassan Elsolh, who really has pioneered bone marrow and stem cell transplantation, I think some 3 decades of experience in that regard. And so I apologize for the brief introduction, but now maybe get on to the topic of this forum, which is to continue the discussions with respect to regulation in stem cell therapies and gene therapies. So, cell and gene therapies are different from the more conventional mature treatments that we are used to, and regulatory systems are essential. They really enable these drugs and therapies to safely get to the market and to monitor them going forward. The FDA support on CAR T cells is one good example. And so we'd like to start with the first question. Can I just move the slide forward? Or? It's not yeah. So our first question for the panel are what are the regulatory challenges in starting cell and gene programs, especially when they are the first in the region. And I would like to maybe start with Professor Hassan Elsolh with respect to his experience over the years in stem cell therapies to respond to this.
Thank you, Brian. First, I would like to brief comment on the debate about decentralization, which from our perspective in the region, this is the only way to go to provide the optimal therapy for a large group of patients in this region. And I think we are setting the steps to move forward, including all the issues related to regulation. And I think we have already some experience, and my colleagues can comment on it, looking at what would be the requirements in order to proceed forward to clear the barriers with respect to regulations of new novel therapies like CAR T therapies and others. First, I think the challenge starts with the institution. I know that this is not something we need to dwell on, but you need to make sure that you have the proper infrastructure to start the program so that you end up with good quality of the product or the processes or the modality of therapy. So you have to look at the challenges of the institution, be it the infrastructure, the IRB systems, so that you are ready for it when then you get the approval from the higher regulatory bodies. Second is, I think, what was mentioned earlier about the role of societies, particularly in our case for the EMD, which would be an opportunity for us. We started, and you asked me, Brian, about what was the experience. We started when we looked at establishing stem cell transplant programs, how to address specific challenges, be it at the beginning with respect to all the requirements for a program, a clinical, laboratory, etc., as well as when we started, for example, the cord blood banking and so on, looking at the regulations, the accreditation, all of that. So you need to look at the infrastructure in the institution and then look at what we can get support from the regional or national or regional societies to help you get the support, be it from the governmental bodies that are required. For example, the Saudi FDA, we have been addressing specific issues with respect to approval of Saudi FDA for specific programs. And I think the dialogue that's been going on for some time yielded in positive aspects with respect, and Dr.s can comment on it, to specific modalities of therapy and gene therapy for patients with retinal diseases. So I think it's important to look at the institution, the region, and definitely to look at what are the governmental bodies that could help you to support the issuing of regulations that would end up in having this product not only available, but with the quality and with the respect to access that is acceptable at the standards, benchmark standards.
You did mention the Saudi FDA and institutional guidelines, but perhaps if you can allow Professor AlHazzaa to comment on her recent experience in the use of Luxturna.
I'm not sure where to start or where to end. It was truly a roller coaster experience, which is understandable. Luxturna, the Novartis, which actually supports it, didn't even know about the name. When I first mentioned Luxturna to them, they did not know what it was. So we had to also contact the global Novartis, who again, we were stereotyped as Saudi Arabia. They had no idea the level of medical expertise that we had. Then, after convincing the global, which they finally put Saudi Arabia on the map, came the Saudi FDA. And it was not easy because, again, they didn't know what Luxturna was. And we have to understand, when we introduced this in Saudi Arabia, it had just been approved in Europe. So we're talking about a month or so time span, although it was approved. So the Saudi FDA finally, I wouldn't say licensed it, but at least approved it. And for us being in at the King Faisal, we didn't really need the Saudi FDA, but it was nice to have it so that everyone can have access. So it has been a challenge. And then the next challenge that of course came in was customs. So again, we had to deal with the customs in Saudi Arabia to be able to bring in a product that could not be opened or x-rayed. So you can imagine the negativity that we got from, but we finally did get it in, and I will say that this roller coaster ride made my husband happy, because I did lose 5 kilos over this past year, trying to get this finally not only approved and recognized and being the first in the Middle East and the 5th globally, but I think more so in doing the patient, and on top of doing the patient, you really, the challenge again, which I think was even more difficult for me than the Saudi FDA, is choosing the right patient. Because you have to remember, in the beginning, we are under the microscope. Anything that goes wrong is actually magnified. This is not number patient 10 or 11. We're talking about patient 1, 2, or 3. That was also another challenge. But I'm happy to say that the vision went from 2,400, for those of you that are not ophthalmologists, from a very big letter to 2050, which in the States she would be able to drive.
Yeah, may I come back to that a little later? But perhaps, you know, it's clear that pharmaceutical companies invest heavily in the development of these new therapies. And I would now like to focus on two questions in this respect, and I would start by asking Professor Elsolh about the complications in accessing new therapies. Now, you must see in your clinics many patients that are eligible for gene therapy, for supplementation, for other things. What are the challenges you face when you want patient number one for a new rare disease in the kingdom to be treated?
Well, first of all, I would like to thank the organizers for inviting me to this panel discussion. And thank you, Brian, for your kind introduction. Now, I think some of the challenges have already been mentioned in a way or another. If I have to divide them into two major categories, one is for approved therapies abroad, which you have just mentioned. So there's a therapy out there, gene therapy, that is already approved. Most of them are very recent. These have their own set of challenges, and then you have those that are under development, and you would like your center to be one of the centers that could be a center for clinical trial for these conditions. So for the approved therapies, there are external challenges which Professor Selwa has already mentioned, and Professor Elsolh has already mentioned. And I think one of the major ones is really to convince these companies to invest in Saudi Arabia. And I think, you know, most of these companies are afraid it's a new product. They don't want any you know, negative publicity around them. Anything that goes wrong probably is going to be very you know, challenging for them. So try to convince them that we are a center of excellence, we have these diseases, and we can deliver excellence in care. I think this is one of the challenges that we face, which is extremely important. Then you have the Saudi FDA, then you have your own local IRB, then you have the customs, which is, you know, we can just tell you stories and stories about our customs and how these medications might stay there in an unhealthy environment, and they can just, you know, get ruined, things that cost, you know, millions of dollars. And then there is the local challenge in the institution to have the setup to deliver these therapies, because some of the gene therapies, of course, require a specific setup. And Professor you know, Hashmi has been chairing this clinical trial unit, which should enable us to really participate in all phases of clinical trials, phase 1, phase 2, and phase 3. The other important challenge, which I think Professor Selwa did not mention deliberately, but I would be courageous enough to mention it, is the financial burden. I think, you know, these therapies are extremely expensive, and trying to find a funding for them is a huge challenge. And I think one of the problems that we face, probably in the Middle East and in Saudi Arabia, is we do not have a national policy for the treatment and, you know, that governs these rare diseases, how they should be funded, who should be approving them, which centers should have the, you know, the approval to deliver these therapies. These things need to be put really, you know, and I think there is it has to be done in an accelerated fashion, because, as you know, the number of approved gene therapies that are coming and the science that is behind this just tells us that this is going to be the way to go for rare inherited diseases and for cancer, many of the oncology conditions. So there has to be a national policy for rare diseases in the Kingdom of Saudi Arabia.
May I now ask Dr. Wonnacott to comment with two hats on. The first I'm going to ask you with respect to your experience from the FDA and as a regulatory body, as in terms of how do you help in this situation. And the second is as a representative of Pfizer. I think with these clinical trials, the FDA and the EMA are obviously of more commercial importance than perhaps the EMEA. How do companies like Pfizer bring to institutions like King Faisal the possibility to access some of these therapies?
Yeah, so I'll do it in two parts, as you asked. First, as my old FDA hat that I used to wear. I think the key there was always trying to find a good risk-benefit balance, right? Is there a potential for benefit to the patient, and what are the risks? And if there's a positive risk-benefit equation, making it work, finding a way to allow the products to be tested and to get to the patients. And so that's key, right? And then from the Pfizer perspective, in terms of bringing products to countries such as Saudi Arabia, I think we think about it, well, I think we should differentiate in two different settings, right? There's the clinical trial setting, and then there's the commercial setting. And in the clinical trial setting, I will say, what we talked about this morning is there's a large number of trials that are happening right now. There's a lot of competition, and the pace of development is very fast. And we have competitors in every product class that we're developing for gene therapy. And so if we're going to include a center in our clinical trial, they have to be able to get their approvals, go through the regulatory process at a pace that will allow us to keep our process moving so that we don't get behind our competitors, right? So pace is a huge issue for us for our clinical trials. And in the commercial setting, I think the key there is being able to leverage the knowledge and experience that larger regulators like FDA and EMA have been able to establish. And it's really about that harmonization that I talked about, having regulators apply the same standards to the review and when we can ensure, when we know that countries are going to apply the same standards that other regulators have already applied, then that really facilitates us getting the products to the patients.
Great. Thank you for that. And I'd like to now move on to the next question. And here I would firstly like a comment from our three physicians, and then Keith to give us some perspective again with respect to regulatory bodies. The introduction of advanced therapies are associated with risks to the patient, the physician, the institution, and the provider of therapeutic options. My question here is, how well do regulatory bodies present and balance the interests of these stakeholders? So if we can start with Professor Elsolh.
Thank you. I think this is a very critical question, because this is when people start new programs with novel therapies, wondering about, do I want to take a personal initiative? I'm talking about a group, not necessarily a person, and move forward with a program that is novel, new, with risks to the patient, the institution, and also to the budget of the organization. And I think the critical point is, again, the infrastructure of the institution, where you have the right team together, not only within specific discipline, with multidisciplines, that multidisciplinary approach that will give the approval for the specific new program at the level of the medical clinical operation. And then you move to the IRB, you move to the higher administration, so that you can get full support with respect to liability. At the same time, it's extremely critical to make sure that you're talking about patients, and your selection of the patient is very important. They fulfill the criteria. Or else you will end up with a situation where your level of risk is very high. You could end up with a bad outcome. And to start a program with a bad outcome, it's very critical for the survival of this program. And this is why when we started, for example, stem cell therapy, even in the late 80s, we were very careful about selection of the patient. And this what supported us, not only with respect to putting the program on the map in the region, but also with respect to the financial challenge. Because we got support, patients were going abroad, and the patients can be treated locally, and you have a lot of safety. The second thing is you have to have the protection from the regulatory bodies, the government, including definitely with respect to Saudi FTA. So the issue of having a specific program, for example, gene therapy for retinal diseases, I know you could have done it based on specific policies and procedures that we have in our organization, but getting support from Saudi FTA is very important, because you could end up with a situation where challenges and questions will be addressed why this was not done at the level of the institution, not with the governmental bodies. The other point that is very critical is to make sure that we have patient education in a way that the patient is fully aware with respect to the challenge. And this is why the establishment of the clinical trial unit, with Sharouk now heading it, put all the guidelines and the procedures, how to provide support for the new programs with respect to liability. And I think all these issues should be taken into consideration when we address specific program and move forward, and should be careful about the balancing the risk and the benefits, as Keith mentioned, in addition to making sure that you have protection by all the bodies, from the institution to the government, Saudi FTA, and even with the Ministry of Health. We have situations where we always make sure that the Ministry of Health is involved directly with the new programs.
So I want to leave a few minutes for the floor to interact. So perhaps a brief comment from Professor Moeen Al-Sayed about the internal processes of our hospital and the Saudi FDA in these respects.
Right. So a couple of points here from my personal experience with some of these clinical trials. Now, in the rare diseases, there are a group of diseases that are rapidly progressive. And it all is about when do you start the treatment, when do you start the therapy. And one of the examples we had in the recent past was acid lipase deficiency, which causes a severe form of progressive liver disease, used to be called Wolman syndrome. So and you just don't know when you are going to find that patient. So the process of getting the approval, the regulatory bodies have to have also an accelerated or a fast-track approval system. And I think that is very, very critical for certain diseases. And in this particular case, I had to really make personal effort to have this trial approved by the Saudi FDA, because I just got a patient who's 50 days old, and we wanted to rush in and give him the treatment, or give her the treatment. Now she's 5 years old and she's doing well. So I think this is one area that regulatory bodies need to be, in the areas of rare diseases, need to be ready to have an infrastructure for fast-track approval for these diseases. The other point I want to make here is that often coming into these clinical trials, the safety data on patients, or previous safety data on that particular drug, is limited, because these are very few patients. You don't have that much in terms of previous or large number of patients. So it's very important for the regulatory bodies to have a track for recording the safety as the clinical trial goes, and post-marketing safety data is extremely important for these diseases, because often you get an approval on a small number of patients and a limited period of time. Because if the trial shows efficacy, then at one stage you have to stop the trial and say, ethically, you have to start these patients on treatment, but you haven't had enough time to have all the safety data. So post-marketing safety data regulation is extremely, extremely important for the regulators to be involved. So these are the two, comments.
Thank you for that. Now may I ask Professor AlHazzaa to briefly give us the part that she went through with patients in the Luxturna trial in this respect. Particularly the internal approvals and the Saudi FDA approvals. To go ahead.
I think one of the most important challenges, especially to the hospital and to the higher administration, the medical, is RPE 65, I call it an orphan disease. It's not a lot, but it's there. And one of, I think, the most important challenges is the hospital thought, once this door is open, there's going to be hundreds and thousands of patients coming in, where in reality, when we collected all the RPE 65, remember, we don't have really a complete registry. I had to do it on a personal level. There was only 17. Now, believe me, 17 is a high number if you compare what they have in the States. So having to recall all these patients, making sure they had the RPE 65, that at some point put the hospital at ease that there were only 17 patients. And out of these 17 patients, which is really, not all of them are going to be candidates. So these patients come to you thinking, oh, I want this therapy. Not everyone is a candidate. So again, the proper selection by a proper expert in getting these patients was really a challenge. The challenge again, when we recall these patients, and I'll reiterate, is when we talk to the global Novartis, we had to, it was like a checklist. We had to go through this whole checklist of saying we have a proper OR. They had to make sure that our OR was capable. This specific surgery is so, how do I tell you, is so delicate that a split second you could lose the whole retina. So they had to make sure not only did we have the OR facilities, that we as surgeons were able to actually perform this surgery. Then they had to make sure about the SDL lab. Then they, again, the pharmacy. The pharmacy was another important thing. They had to come to us and give us a trial of over and over repeating it to make sure that this medication could be handled by pharmacy. And as Dr. Rafiq mentioned, you have a window span. Once that medication is thawed, you literally have 4 hours for it to go from the pharmacy, come to the OR. When it comes to the OR, I and my co-surgeon have to identify it. Then we have to put the patient to sleep. It's usually a child that can take up to 30, 40 minutes. We have to do a complete vitrectomy. I'm not going to go into that. The process literally takes 5 seconds, but the preparation, and then you're also beating time because you have 4 hours, and if you don't do it in those 4 hours span, you will literally take a 3 million Riyadh, $850 medication and throw it in the garbage. So the challenge was there. It started from when we first identified it to trying to prove to the global Novartis, then coming in. I remember when I first heard about this, I didn't know who to approach. At that time, Dr.s was in what we call the CTO, Corporate Transformation Office. And I think if it wasn't for Dr.s passion and his support, we would not have been the first in the Middle East, the 5th globally, to do this case. So again, you get into this dilemma, who do I go to? So it was the CTO that actually initiated it, and it was the research center, which was Brian, that adopted it. So it wasn't even mine. Although we were the surgeons, we didn't mind. It was really too many hands, if you will, in the soup. That's what I call it.
Thank you. I think the common message is that the path is long, and I want to sort of conclude the session with Dr. Wonnacott now to answer the final part, which is, I think the regulation of novel therapies is clearly essential. And where is the line between facilitation and prevention with respect to the interest of the patient, the physician, the institution, and the community? So if perhaps I could give you 2 or 3 minutes to wind this up for us.
Yeah, so, I think that as we've been hearing all day, the key is benefiting the patient, right? And so looking for opportunities to get the patients what they need. And I think, as we heard, with Luxturna, it makes a major difference in the patients' lives. And so it's pretty rare as a pharmaceutical company that we have centers coming to us demanding that we, bring them our product. We love them, by the way. Thank you. But when you have a product like that patients really want, right, then our job is to get it to them, right? And when I say our job, I don't mean just the pharmaceutical company. It's the whole community, right? Our job as a community, as regulators, as healthcare providers, as patient advocacy groups, and as the pharmaceutical industry, our job is to get patients the products that will make a difference in their lives. And we at Pfizer are really interested in partnering with all the groups, all the stakeholders to make that happen.
Thank you so much. And with that, I'd like to, I think we've run out of time and we need to conclude here. There may be an opportunity to talk to each of our panel members following the conference. I would like to thank you for your expertise and your valuable comments. Thank you so much.